Have you had a headache while eating cheese? Have you had a headache while eating chocolate? Have you had a headache having chocolate-covered cheese? Have you had a headache drinking red wine while eating cheese and chocolate? Have you had a headache during your period while menstruating? Have you had a headache eating chocolate during your period? I bet you have. Have you had a headache eating chocolate-covered cheese balls while menstruating? Then you likely have had a migraine. Have you had a headache while eating chocolate-covered cheese balls, while drinking red wine, while menstruating? Then maybe you have a migraine, a hemigrania. Now, these associations with chocolate, cheese, menstrual flow are real associations, not made-up associations. The other part about migraines is that migraines give you pain, but they also give you visual disturbance. They give you visual disturbance. They give you flashing light flashers. They give you floating black dots, flashers and floaters and visual disturbance. Ocular migraines, flashers and floaters and visual disturbance. And then ocular migraine, flashers and floaters and floaters and flashers. Flashers and floaters, oh my! The world looks bad to your eyes when you have a migraine with flashers and floaters and visual. But the examination, unless you're the rare person that has a complicated migraine, and complicated migraine means a migraine that's so bad that there's so much spasm that you actually have focal neurologic deficits. Complicated migraine is so bad that it actually gives you focal neurologic deficits. Complicated migraine. But except for that person, where you have so much vasospasm it actually starves off part of your brain, the exam is normal. You don't see anything on the examination. You don't see anything on an MRI or a CT scan. You don't see anything on an EEG. All of these tests are normal. And the exam is normal in migraines, but you have visual disturbance and ocular migraine, facial numbness. Now, by the way, of all the things that bring on a migraine, what's actually the most common? It's actually emotions. The most common thing to bring on a migraine is actually emotions. Emotions bring on a migraine. That's the most common thing. Now, a cluster headache is called a cluster headache because the pattern of pain. The pattern of pain is that you have multiple short 10 minutes, 20 minutes, 30 minutes headaches, and multiple in a short period of time, then they disappear. They can come back next year. So it's called a cluster headache as a symptom pattern. And although it's true that your eye is red, your eye is tearing, you have nasal stuffiness. You have nasal stuffiness because your eye is red, your eye is tearing, and you have nasal stuffiness. The name cluster headache refers to a symptom pattern. The name of cluster headache refers to the symptom pattern. Cluster headaches are called that way because there's multiple, and they're short, and they're in a short time period, short duration, and they recur. Now, cluster headaches are almost exclusively unilateral. Migraine headaches can be unilateral a third of the time, 40% of the time, 60% of the time, but 90% of cluster headaches are unilateral and often hit men. So What do they both have in common is the abortive therapy. The abortive therapy is the same for both. The triptans are abortive therapy, and ergotamine is abortive therapy. The triptans and ergotamine are abortive therapy. Triptans and ergotamine, and the abortive therapy is the same for both. Now, this is one of the big things for you, is to be able to know what the abortive therapy is different from prophylactic therapy. The abortive therapy of triptans and ergotamine both reconstrict the vessels. They both reconstrict the vessels because we think that these headaches, or at least migraine headaches, we think that these headaches are vasoconstriction followed by vasodilation. Then when you have the vasodilation, you get the pain. They are constrict the blood vessels, then you vasodilate, then you get the pain. So that's what we think that these headaches are from. So the triptans reconstrict you. Ergotamine reconstricts you. That means you can't use these drugs when you have diseases. They are not to be used when you have coronary artery disease, not to be used when you have severe hypertension because it'll constrict you more, not to be used in pregnancy because we don't want to constrict that baby. We don't want to constrict your uterine arteries and squeeze the baby. Then instead of nice healthy baby, the baby gets squeezed and comes out of the vagina like soft ice cream. You got 3 flavors of ice cream: vanilla, chocolate, and baby flavored. So we don't use these when you have coronary disease and hypertension and pregnancy. So abortive therapy, triptans, ergotamine. Well, what are you going to do then if you can't use the triptans? And the answer is you can also, as an alternative, use 100% oxygen. There's 1 or 2 sources out there, and 1 or 2 of the review course that talk about 100% oxygen first. It's not correct. It's very hard to give 100% oxygen. You have to have the equipment at home. You just can't walk down to the local CVS and Duane Reade and Rite Aid and just like, hey man, can I have a little prescription for 100% oxygen? No problem, here's your ventilator. Triptans and ergotamine constrict you, but you can't use them with coronary disease or severe hypertension or pregnancy. So here you can use 100% oxygen. In migraine, you just have to use pain medications. Now, the other big question is you knowing what prophylaxis these. How do you prevent them? Well, it's very straightforward. When you have more than 3 or 4 of these a month, we prophylax you with beta blockers, non-specific beta blockers, propranolol. Non-specific beta blockers, propranolol. Matter of fact, one of the few last remaining indications for propranolol as a non-specific beta blocker is to prophylax migraines, thyroid storm, And the prophylaxis for cluster headaches is the calcium channel blocker known as verapamil. The calcium blocker known as verapamil. Now, there are a whole range of other prophylactic medications, all of which are good for neuropathic pain. As long as we're on that subject, we can also say, well, they're also used for some people who have trigeminal neuralgia. They're used for people who sometimes have post-herpetic neuralgia and peripheral neuropathy, post-herpetic neuralgia and peripheral neuropathy. And a lot of these drugs have a lot of overlap, which is to say, now it's true that we can use beta blockers first to prophylax migraine headaches, verapamil to prophylax cluster headaches, because these are vascular headaches. But the thing is that the carbamazepine is a pain medication too. It's not just a seizure med. Carbamazepine is a pain medication. It's a seizure medication. Neuropathic pain. And pregabalin, gabapentin, phenytoin, valproic acid. Did you know that seizure medications, almost all seizure medications, also work for neuropathic pain? Most people don't know that. Seizure medications work for neuropathic pain. Phenytoin, valproic acid, carbamazepine work for neuropathic pain. Seizure meds. Phenytoin, carbamazepine, valproic acid, pregabalin, gabapentin. So you have 2 types of answers. The first answer is abortive therapy, triptans, or ergotamine. The second type is, what's the prophylaxis? Beta blockers for migraines, verapamil for cluster headaches, carbamazepine for trigeminal neuralgia, for post-herpetic neuralgia, and Peripheral neuropathy, gabapentin and pregabalin, or tricyclic antidepressants. Seizure meds also work for neuropathic pain. Seizure meds also work for neuropathic pain. Seizure meds also work for neuropathic pain. And the other answer is, what if the beta blockers don't work for your migraines? What if the verapamil for your cluster headaches? What about the post-herpetic and the peripheral neuropathy? What about if carbamazepine is not working for your trigeminal neuralgia? Then the next step is, we don't know what clear answer there is. You try phenytoin, you try valproic acid, you try a whole bunch of seizure medications until you find one that works. Trigeminal neuralgia, sensory nerve, slight touch, ow, chewing, ow, little touch of the face, ow. It's absolutely excruciatingly painful to the people who have it. It's excruciatingly, horribly uncomfortable to the people who have trigeminal neuralgia. You have no idea how uncomfortable trigeminal neuralgia is to people. People describe it as if somebody walked up to them and stabbed them in the face with a hot knife. It's horrible. Stabbing it in the face with a hot knife. Carbamazepine will work in most patients. Then you use a second seizure medication, phenytoin valproic acid, and the last thing is surgery. And you might say, well, then you won't be able to feel your face. And that's true. But if you've ever talked to someone with trigeminal neuralgia, they say that they'd rather have their face cut off than feel the pain of trigeminal neuralgia. Tic douloureux. What's the word douloureux? Sadness. Sadness. It's horrible. Incapacitating. Incapacitating. Post-herpetic neuralgia and peripheral neuropathy in general, like for instance people who have diabetes, gabapentin and pregabalin are the best things we can do. They decrease the pain by 50% in 50% of the patients. There is no truly good medication for peripheral neuropathy. The seizure medications are tried, and we don't know what else to do. Diagnostic test is nerve conduction studies. Now, I'm going to give you the follow-up quiz to the stroke section. Here's the follow-up quiz to the stroke section. A 62-year-old woman, man, doesn't matter, comes with a loss of consciousness and dizziness. They wake up and they got weakness of their right arm and ataxia of their left leg. And they have weakness of one side, ataxia in another, and sensory disturbance of their right leg. The head CT is negative. The most accurate test is, of course, an MRI. Most accurate test is an MRI. And the echocardiogram shows nothing. The Holter shows nothing, no AFib. And the carotid Doppler shows an 85% stenosis of the right coronary. Right carotid. What is the management of this patient? Okay, well, certainly they get thrombolytics in the first 3 to 4.5 hours, aspirin if they come after 3 to 4.5 hours, clot retrieval with a catheter after that, up to about 6 hours, add dipridomol, switch to clopidogrel. What do you want to do about the carotid stenosis at 85%? What are we doing about the carotid stenosis at 85% stenosis? And the answer is that we're going to do the very clear treatment called not endarterectomy. Not endarterectomy. Not endarterectomy. We're going to do no endarterectomy because endarterectomy is not for asymptomatic carotid stenosis. And this person has a posterior stroke. This person has a posterior stroke. This person has loss of consciousness, dizzy, bilateral findings. This person has vertebral basilar insufficiency. I bet a lot of you said to do surgery because it's 70 to 80 to 99%, but it's not the problem because this person's problem's in the posterior. So let's say that you went to plastic surgery and you said, doctor, my ass is too big. I don't know who would say this. I don't think there is such a thing. And you say, I have a posterior problem. Can you cut it? And you wake up and you find that he's done a nose job and I've got breast implants. And you wake up and you say, I don't understand. I have a posterior problem. Why did you cut me anteriorly? Don't cut the anterior circulation for a posterior problem. This is asymptomatic. See you soon.